Brian, thank you for that, Joe. Brian, you started the program after Joe came to visit. So Joe comes out to visit us. And then where did we go after that?
So Joe came in October of 2013. And what we did is we decided to seek out the key physician leaders in our organization from whom we thought we needed support for this program. So we selected, we sought input from folks that were in departments where these sorts of incidents are more likely to happen, in the OR, anesthesia, surgery, in the ED, in the intensive care unit. Not that they don't happen everywhere, but those are sort of the hot spots. And we asked folks if they thought that this was going to be helpful. They asked, we sort of talked to them about the program that they had at Brigham and Women's. It helped that it was a good program that was already established at a really high reputation organization. And what we found is people really almost immediately recognized that this might be a good idea at Stanford as well. So we were fortunate that way. We weren't meeting resistance. And what we were doing is just gathering allies to make this work. And so what we did is we decided to go ahead and start training with Joe's help after her. I should say also we had the site visit from Joe, and she visited our wellness committee. We invited people to come and hear the discussion there. She was able to visit some of the leaders of our medical center as well, our dean and others. And there was support all around, and we went ahead and decided to start training peer supporters. And we followed a lot of the practices that Joe had worked out already in Boston. We trained mostly folks that were already on our wellness committee, but also some others we asked all the chiefs of service in our organization to recommend people who they thought might be excellent peer supporters. Because when we got to do the peer supporting, we often want to use supporters from the same or a sort of a related specialty to do the peer support. So all of our peer supporters attended initial and then ongoing peer support training. We made it very clear to everyone along the way that this is not mental health, that this is, and we do have a mental health connection called Well Connect that is available for folks that really do need that. Usually that's not the case after these incidents. Usually the peer support is what folks need. And we want to be very clear that that it's not a psychiatric disorder to have distress and to need help after an event like this. We developed a process, again, modeled after what Joe had done. When an event happens and we learn of it, the peer support director is notified by risk or by the quality department or by anyone else in the organization. And as we've progressed through the early stages of this, we've gotten more and more awareness so that people start to tell us about these incidents earlier on. The director contacts our peer support team. The peer supporter contacts the person involved. We didn't have to go through the learning process of waiting for them to come to us. We contact them by phone. We send them an email containing the options. It suggests that you call. It doesn't demand it. Materials about the program are sent. We have a very careful scripting of the call and the email so that it's well received by the recipients, doesn't feel in any way threatening or violating of confidentiality, that sort of thing. And the process slide here includes for our house officers. And we'll get into that, but basically one of the supporters is available to meet with the person who was involved in the incident. I think about 50% of folks that were contacted are taking advantage of that. And then our risk department keeps track of the metrics in terms of how many people do that. And the feedback that we've gotten in terms of anecdotal report are things like you see on this slide. We really enjoyed the training from our trainers. It felt like the organization is showing appreciation. Folks that are contacted by this peer supporters have been almost unanimously very appreciative, even when they said they didn't need peer support after an incident. Early on, I was doing some of this myself, and I can tell you that there was just a palpable sense of appreciation, that somebody cared, that somebody was asking how they were doing, especially when I contacted house officers. And I have to say that some of the house officers relayed stories of feeling very isolated. Their attending didn't ask, they didn't know what to say. They didn't know how to ask. They had to go right back to caring for patients after they had an error. And they really were suffering. And I feel like just from my own brief experience, because I have not been an ongoing peer supporter, that it was really quite impactful. And then as the program has gone on, we find clinicians self-referring to the program as well, that they know we exist, and they reach out to us once in a while. The house staff program came after the original one with the medical staff. And originally we thought, well, the house officers, what we'll do is we'll find young faculty who can mentor or can counsel them, because they're only here for 3-5 years, and it's going to be hard to train them, and they're so busy and they won't be able to do this. But as we met with the house officers in order to plan the program out and get buy-in from them and from Larry Katz-Nelson, who's our head of graduate medical education, we did some focus groups, and they were not interested in the faculty doing their peer support. They wanted to do it themselves. We were really heartened by that. They were absolutely interested in putting in the time to do the training. The chief residents felt like this should be their responsibility, and they really stepped up, and that was something that really made us all very excited. And so they're doing this themselves. They have a faculty peer supporter on their team that helps them, that counsels them and helps with the training, and that's been working out really well. We're not that far into it. It hasn't been that long. The medical staff program only started in June of 2015. We have 41 interventions since then, including, and for fellows, we've been using young faculty members. We don't have that one figured out totally yet. We began surveying the folks in terms of how they're feeling about the interventions. We have 15 trained peer supporters between the children's and the adult hospital. And that's for medical staff. In the house staff side, we began later. We began about 6 months later. We have 8 house staff members who are trained to do support. We've had 13 interventions. Training is going to now be offered to all of the incoming chief residents, and then selected residents as well are invited to take leadership role in the program, so we have some continuity between the years. And the resident peer supporters, as I said, they have faculty advisors as well. So it's been extremely well received. The early indications in this program are that people appreciate it, they benefit from it. There were a lot of early concerns as we did our focus groups about things like confidentiality, about legal risk in terms of talking about things, and maybe Dana could speak about that at some point, but there is no real problem with that. And those concerns really have just melted away as the programs become more ingrained in the organization.